Good morning, everyone. Welcome to the American Thoracic Society town halls. Today, the Assembly of Pediatrics is going to be presenting on the Pediatric Interventional Pulmonology Town Hall on cryotherapy. I'm Pooja Mishra. I'm one of the pediatric pulmonologists at Helen DeVos Children's Hospital, and I'm one of the moderators for today. We have two other moderators. So we have Dr. Matt Wong, who is a pulmonologist from the Children's Hospital of LA. And then we have Jane Taylor, one of the pulmonologists from UPMC Children's Hospital of Pittsburgh. And to start us off, we have our first presenter. We have Jorge Valencia Rico, who is a second-year pulmonology fellow at the Children's Hospital of Colorado, and is going to be giving us some background on the interventional pulmonology cryotherapy.
So we're going to talk about pediatric interventional pulmonology, the topic of cryotherapy. It's a group of panelists, and we'll have some time at the end to chat more. So some of my disclosures, and to begin with, we have three objectives today. The first one is to cover what cryotherapy is and how we got here, the overview of the current applications, techniques, and outcomes, as well as the strategies to advocate for cryotherapy training and experience both during fellowship and early career. What is cryotherapy? So cryotherapy is a type of technology that uses a rapid freeze thaw cycles, and it has two properties. One of them is the adhesion component, and the other one is the ablation. These two properties serve three main purposes. One is the extraction, the other one is biopsies, and then it can be used to recanalize the airway as well. The way to use the cryotherapy is through either contact cryotherapy or spray cryotherapy. We're going to focus on the contact cryotherapy during this lecture. And something that is important to know before using cryotherapy is the tissue properties. Some tissues are cryosensitive and others are cryoresistant. Those that are cryosensitive are usually high water content, like mucous membranes, tumors, granulation tissue. And those that are cryoresistant, it's the cartilage, fat, fibrosis, nerve sheath, connective tissue. How does this machine work? It's through the Joule-Thomson effect, and we have on the left pressure 1, temperature 1. We have on the right pressure 2, temperature 2, and these walls are insulated. So it's basically a compressed gas. In this case, could be carbon dioxide or nitrous oxide. That will be on the left side, and that's released through a small opening. In our case, would be the tip of the cryoprobe, and the gas expands rapidly. That temperature drops, and the cold that is generated is transferred to the surrounding tissue. So the first time that the word cryotherapy was around was in the early 1900s. But the cold as a form of therapy has been used as early as 3500 for inflammation and injuries. The first pediatric use of the cryotherapy through a rigid cryoprobe was back in 1975. This is a brief summary, 2 cases of granulation tissue, tracheal strictures in early as 2 years old, with the outcome of extubating or eradicating the granulation tissue. The first bronchoscope with a 1.2 channel we know was developed around 1980, and the first cryoprobe, the 1.1 flexible, was FDA cleared around 2020. So it was about 40 years to develop a flexible cryoprobe that will fit through one of our most commonly used pediatric scopes. So you should have seen the looks I got on the trail, hauling all these things up here, but to the right you can see the cryoprobe. There is a 1.1, a 1.7, and a 2.4, and to the left, this is the start button, and there is a timer that is useful depending on the freezing time you want to use, whether you are using it for the adhesion or biopsy properties. This is an example of the use of cryotherapy. To the left, you can see this is a cast in the right-sided, and then this is us using the cryoprobe to extract this cast. So you're just coming in contact with the tissue. You want to be as far as possible as to the airway and the healthy mucosa, the walls. That's the freezing, and that's the extraction portion. It's a long piece of cast. And this is after the airway was clear. And this procedure would have taken like hours through the suction channel. And with this cryoprobe, it's a matter of minutes, 10, 15 minutes. So there is highly benefits of using this technology. Now, even though pediatric pulmonology still lags behind the adult interventional pulmonology, this paper does a great job highlighting all the work done in the pediatric community. And what I like about this paper is how they divide it in properties. So here you can see the cryoadhesion indication, and there are 3, 4, 5, 6, about 8 papers. And you have the ages, complications. If you talk about recanalization, same here. There is evidence supporting that this is being done more commonly in the field of pediatrics, and for the cryobiopsy as well. There are papers supporting the use of cryotherapy, both for endobronchial and transbronchial cryobiopsies. One of the advantages of using the cryoprobe is that compared to other technologies, it doesn't require reduced oxygen concentration. Sometimes we get bigger specimen size and the morphological structure remains intact. There is higher diagnostic yield compared to the forceps biopsies. And looking at the complications of the using of cryotherapy, this is a paper from 2022 and 69 procedures of cryotherapy. We can see divided in 3 sections: foreign body removal, airway obstruction, and biopsy. There was no death, technical difficulties, or airway ulceration or perforation. 2 of the patients that needed a biopsy ended up having a pneumothorax. 1 of them required a chest tube that lasted less than 48 hours. But even though we have 69 patients, is evidence that it's supporting this. There is an abstract also 2025. These are 94 procedures in 40 patients, and mostly for recanalizations and cryoextractions. There was no severe bleeding or pneumothorax. There were no additional interventions, and mild bleeding was grade 1 and 2 in 25% of the cases. This is a 5-year single center experience. It was overall is a safe and well tolerated with minor bleeding, and we need to continue to work on these to assess efficacy and safety across pediatric populations and different conditions. So what is the first step is what programs or institutions is going to be more easy to access to this technology is those that are larger pediatric hospitals or hospital within a hospital model. It's going to be more difficult in there's no interest among faculty, fellows, if there is a lack of expertise, if there is limited funding, or if there is limited procedural demand. But there are ways to overcome this, and I'll let the panel experts talk about it a little bit more later. So this is not in any paper, but it's something I've been thinking about. How can we group the things we can do with the cryotherapy? So group 1, 2, 3, and 4. So if I had to group them, I would say group 1 would be foreign body extraction, clots, casts, and plugs. Group 2 would be those in the endobronchial biopsies. Group 3 and 4, they have a star. Since they are more advanced procedures, airway recanalization, sometimes it needs another techniques on top of the cryotherapy to recanalize the airway. And then the group 4 would be transbronchial cryobiopsies or EBUS guided cryobiopsies as well. The 5 pearls I want to give to everyone in the audience, especially as a fellow, is that the most important thing if you want to build expertise and training in cryotherapy is curiosity. Always asking like, okay, what's in the package of the cryoprobe? What do I use this? When do I use this? What channel do I need this for? What scenarios? Keep up with the literature. And then master your normal anatomy is fundamental, as well as looking out for like courses or training conferences, ATS, AABIP, or depending on what part of the world you are. Become a hunter and over prepare one. Even though we have evidence that this is a safe procedure, we still need to better understand, is this because of the volume that it's around in pediatrics, or because compared to adults, they do more cases, right? So I think it's always good to have to be prepared. What do I need before, during, and after the case, and look for cases that are being done with a therapeutic suction channel that are taking like hours. And then if you have access to this therapy, you can shorten that time. Share your cases with your co-fellows. If you've done a couple cryo, you feel comfortable, call the first year fellow, call the second, call your third year fellow, and say, hey, I have a case. Do you want to come? Do you want to join? Do you want to drive? Do you want to do it? Same for your attendings, and then publish all the cases because we need to grow more evidence on the field of cryotherapy. One piece that is also crucial is staying connected and grow your network. I personally like the PubMed alerts, and not just the pediatric literature, because we're learning from the adults. So including, depending on what's your topic of interest, in this case, cryotherapy, adding and understanding what are they doing, what are they doing with the cryoprobe, transbronchial biopsies, what are the outcomes, and see same thing for pediatrics. Become a member of professional societies. So ATS is a big one, AABIP, and then depending on where you are, Latin America, Asian, European societies, they're building their interventional pulmonology groups and societies as well. And then for those group 3 and 4, the ones that I showed you in the previous slide, the recanalization biopsies, it's a good idea to collaborate with your nearest adult interventional pulmonologist, because they do this all the time. They know how to handle most of the complications. So collaborating and working together is key to continue to prove and continue to show good outcomes in the field of pediatrics. One of our recommendations is if you have an interesting case, submit it to the ATS, the library, bronchoscopy library, and I'll see you next year if you come to Denver at the AABIP session 2026. That's all I got, and I'll let the panelists continue the talk. Thank you very much.
Thank you so much for that, Jorge.
My pleasure.
Agreed. Great job, Dr. Rico. So my name's Dr. Matt Wong. I'm a pulmonologist at Children's Hospital of Los Angeles. Thank you everyone for joining this town hall this afternoon. I have the pleasure of introducing our great panelists who are going to kick us off on this next portion of our town hall. So our panelists are Dr. Pelton Phinizy from the Children's Hospital of Philadelphia, Dr. Chantal Grant from the Icahn School of Medicine at Mount Sinai. We have Dr. Kubra Melike Bozkanat from the Stanford University School of Medicine, Dr. Emily DeBoer from the Children's Hospital of Colorado, and finally, Dr. Sara M. Zak from the Cincinnati Children's Hospital. Thank you all for joining us. I will kick us off with our first question. And that is, if you guys could share how you started interventional pulmonology with cryotherapy.
I'd be happy to start. I was a fellow at UT Southwestern Dallas, and we had a lymphatic referral center, and we had quite a few plastic bronchitis patients. And if you don't use cryo, those bronchs take hours, 2, 3 hours, where you try to piece out the casts, with like small steps with the forceps. And if you try to call ENT to see if they could do rigid, it just becomes a bloody mess because, cardiac kids tend to bleed. So I went to the adult side to learn a little bit more about cryotherapy. And once we started using cryo for plastic bronchitis casts, it made such a big difference.
I'll add another great place to use the cryoprobe is if you're an ECMO center. A lot of these kids will bleed into the airways, and helping the ICUs when they're done with their ECMO run and they're getting off of lung rest, and you want to re-recruit the lung, helping to remove some of the clot with very carefully remove the clot with cryo. Can be quite helpful. Also, patients that have pulmonary hemorrhage for various reasons, or diffuse alveolar hemorrhage, and you need to clear out clot. We've had a couple of surgical emergencies where we've been called in, and the cryoprobe can be quite helpful over the next few days to help recanalize the airway.
So I learned cryotherapy probably the hard and scary way. I started with a patient that had GPA and she had advanced airway disease. And we had access to the cryo machine because I worked at a center that has a very robust interventional, adult interventional bronchoscopy team. And so we already had the cryoprobe there. And Dr. Vicencio, who is my mentor, had used it a few times for simple things like pulling out casts, but we knew that there was a place for it for recanalizing the airway. And she had multiple tracheal lesions. She had some webs, she had stenosis. So she had multiple things going on from her GPA. And I started off with just biopsying the lesions. Then we did some balloon dilation in conjunction with cryotherapy, and I had her come back. We were probably doing surveillance bronchoscopies on her like every 2 to 3 months until her airway looked more stable. So I say it was a scary way because anyone who has used the cryoprobe for the first time, it does take some getting used to with pulling for biopsies and the time it takes for the freeze and thaw cycles. You may be a little bit hesitant because of how long it takes to freeze and thaw over and over again, and you don't necessarily think things look great initially. But after doing it multiple times on this one patient, I learned a lot about how the cryoprobe worked. And at that time I was using the reusable probe, which we don't use anymore. But just with that one patient, treating her multiple times over the course of maybe like 2 years, I learned so much about the probe and felt much more comfortable. After doing the case with Dr. Vicencio a few times, I would say like he was with me maybe like 10 times. I felt comfortable using the machine by myself because at that time we didn't have any courses. So every time I did it with him, he just did less and less, and I looked at him less and less and felt much more comfortable. I think everyone learns differently and may take others, longer or less time. But for me, after doing it with someone that had more experience a few times, I felt much more comfortable. And again, I think doing those difficult cases probably sped up my learning. And so after, I would say like about 10 times with him in the room after that, I didn't really feel like I needed him anymore with cryo.
Thank you. I think that's something which all of us think about as we're getting into this cryotherapy journey in terms of what is the training available for someone who's looking for this in terms of formal training. And also like sort of to piggyback off yours, you talked about how within 10 to 15 instances of using it, you sort of felt comfortable, but would love to hear from the group in terms of how long it took for them to feel comfortable.
So I'm gonna do both. Our story was a little bit different here. We had 2 patients who had a retained foreign body that no one ENT. There were multiple attempts to get them out from the distal right lower lobe, and so the ERB rep came and we got contracting together. And our first cryo was on both of these retained foreign bodies with loaner equipment from ERB, with the ERB rep with us, who basically trained us at that time. And my medical director said, if this goes well, we'll buy you one. And I was like, okay, no pressure to do the first one for a patient who really needs it. And this is the chance. And then we'll move forward with this. So luckily, they were cryosensitive foreign bodies, and it was like a snap. But I've told other people this, like the night before your first cryo on your own is not the most restful sleep that you've ever gotten. And that's a good thing. That's like this is really important, and I am doing something new that I haven't done before, and I am not surrounded by a bunch of people who've done this before. But just to like circle back to Jorge's slides, like I am an expert in bronchoscopy, and I know the anatomy, and I know the risks, and I handpicked my anesthesiologist and the ENT who stood next to me, and then in 5 minutes the foreign body was out, and we were like, okay, that was a lot of stress for something that was an easy case to start. But having the ERB rep with us hands-on was a really nice, like, I'm here doing it and practicing on a gummy bear, and then they're in the OR with me if you don't have an adult pulmonologist or a trained someone with you after you've done good training at all the courses that are available. But it's one good route.
Yeah, there weren't any courses when I was learning how to do cryo. And I think, like Emily said, using your reps to help teach you the equipment. So you're understanding how everything works, having them there if there's any issues to help troubleshoot, especially the first few times. And then making sure the rest of your staff is trained and familiar with how to use this. So we have dedicated respiratory therapists in Cincinnati, and they all go through training on the equipment as well. And so we are all learning how to use this before we use it. And then just making sure that you have really good communication with your team in the OR as you're doing this, whether that is your assistant who's helping you do the procedure, your anesthesiologist, what other team members do you have in the room, ENT, general surgery, who else do you need, and making sure that you're communicating this and talking through what you're doing, because that becomes really important for patient safety, and just making sure that everybody is understanding risks, benefits, what we're doing for things like foreign body, making sure that you've got like the airway situation sorted out. Are you going to need to go through an artificial airway? Do you need to quickly reintubate or have anesthesia ready to reintubate? And so the more you do it, the more comfortable you get with these things. And so volume is really helpful in that regard. And the more that when you have it available, think of new applications for it. You're like, oh, I can use cryo for this. And it ends up being really helpful in a lot of different ways.
That's great. It sounds like many of you guys learned trial by fire. But would you be able to share what formal trainings are now available for any pulmonologists that are really interested in ramping this up at their institution, really getting more comfortable with the didactic portion of it as well? And I know, Dr. Zak, you mentioned like support staff. So is there once you're kind of comfortable with it too, kind of what strategies to get kind of the support staff also comfortable as well?
So currently, ATS is going to offer another postgraduate course in 2026 in Orlando. We've had a postgraduate course at AABIP in Austin this August. So I would make sure to kind of follow both institutions. But besides that, as far as I know, Cincinnati will continue to offer yearly cryotherapy courses. And Chantal, you can tell me more about the Mount Sinai course. I don't know if you guys are doing it yearly now or more or less frequently. And then hopefully in the West in June 2026, we're planning on a cryotherapy course at Stanford as well.
Yeah, so Mount Sinai does host a cryo course every March. I don't have the exact dates, but I usually, Dr. Vicencio, he runs the course and usually sends out multiple emails, but we send it throughout multiple forums. So hopefully if you haven't heard about it, you can definitely just reach out to me directly. I'm happy to share my email with everyone. But Dr. Vicencio, he's not on this town hall right now, but he's the one that organizes it, and we plan to have it in March of 2026.
Yeah, our Cincinnati course is in September every year, and hands-on course for the cryo session. And then at other conferences, so at the air digestive meeting in the fall, we've had a hands-on cryo session. It's much smaller, but gives you the opportunity to see the equipment, to get some hands-on experience with the equipment. And then some other conferences, both nationally and internationally, have had similar cryo sessions that have allowed people to just get a little bit more experience and exposure to the equipment.
And the fellows and your fellows who attend fellows track at ATS every year and the residents incoming boot camp will get exposure to hands-on cryo, but they should not come back and tell you they're trained after their 30 minutes of fellows track. So don't let them fool you.
I think that's just a really good point to make overall, because just doing one of these courses does not necessarily certify you to be an expert in cryotherapy, and you should be going out and doing mediastinal mass, cryobiopsy, right? You still need to have the proper training in lots of different areas. You need to be very, just like was mentioned in the talk earlier, be very comfortable with a bronchoscope, know what you're going to do if there are going to be complications, and be prepared for those sorts of things. But doing these conferences can do a lot for getting you much more comfortable with using it and getting ready to start doing so.
And I think that brings us to our next question in terms of things. So you've gotten some amount of exposure to cryotherapy, you've done a little bit of it, but then bringing it back to the institutes for people who've helped build up a cryotherapy or like helped other institutions. From an institutional standpoint, how have you managed to work up your cryotherapy program or build it up, and what needs to be done?
I'll start.
Pelton, go
Sorry, go ahead. No, please.
Well, so it starts with interest, and then partnering with your business team to build a business plan. And there have been lots of people at institutions emailing Cincinnati, CHOP, and Mount Sinai saying, tell me how many scopes you do, tell us how many cryo you do, what's your reimbursement, because that's what your business team needs to know to make a business plan. Cryo is one of the cheaper and easier interventional equipment to get comfortable with and to get the investment in your hospital. So the first thing is figuring out how does your population compare to the other big institutions? How many do you think you'll do? And then how much will you kind of lose if you don't have that capability and you have to send patients elsewhere? And do you have all the resources to have RT trained and to have it available and to do it safely and successfully? So that takes some numbers and takes some strategy of like, do we have this here? And then I would echo what Sara said, is that once you get that, like, we're doing this, we have it, and we're here, and we have enough people trained, it's like, and I mean, we have Jorge, so he's our expert hunter, but he's like, there's a cast over here, and I need this here, and we need this here, and everybody come together. And once you build it, you'll find cases to use the cryo, as long as you have a robust bronchoscopy program.
And Emily, I will dovetail on what you had mentioned when you're building a business plan. Remember, pediatric pulmonology is not in a silo, and there's a lot of other groups that also benefit from this, like heart transplant patients. So transplant tends to have more finances and some more robust business plans. So partnering with different groups is also a good strategy to get equipment.
Right. Once word gets out amongst your PICU friends, your cardiologists who have Fontan patients, and they're going to have plastic bronchitis at some point, once word gets out about the benefits that you can bring to these patients in the hospital, the number of cases will go up. So you can also try and find friends to share the costs, I think, like like Emily and Jane are implying.
And I think if you're at a facility that is paired with an adult hospital, like Chantal says, you may have access to equipment already that you can borrow, and not necessarily need to purchase your own equipment.
Also learn the numbers, how much does a cryo machine cost? The cryo probes themselves, as they get smaller, they get a little bit more expensive. But if you start billing them to the patient's insurance, the hospital can actually make a small profit off of those. Make sure you know your billing codes for cryo. So there's actually, a lot to learn, but I do feel like as pediatric pulmonologists, we don't really focus on the finances too much, but it does help in this case.
Thank you guys for sharing all those tips as well. Since many of you guys come from programs that are pretty much established at this point, are there some lessons learned that you could share, like growing pains, the first, couple cases, other kind of strategies or other things to look out for other centers that might be interested in looking into this more and kind of looking at how to grow their program or even start a program?
I'll start. I got stuck at the buying process initially because the cost of the cryo unit was right at the cutoff of capital purchase, and capital purchases at Stanford, it takes a while for them to get approved. So and I didn't know what to do, and then I learned that you could actually lease the equipment, which is, you kind of bypass that capital purchase process, but you still obtain the cryo unit for a certain period of time until you can buy it.
Like, I have a quick question. If the machine is leased, do you get a better price at the end if you want to buy it? Or do you still have to pay the full price?
You probably pay the full price. It's worth it though.
One of the things that I was worried about, and I actually was looking at the CHOP model, was once we have cryo, is it 24 hours? Like, can people call us 24 hours a day to get an ECMO bronch with cryo? We don't have, and the answer is mostly no at our institution right now. So we have a number of faculty who are comfortable with cryo extraction. We don't do more complicated cryo procedures with every faculty member, but we probably have about 10 who can do cryo extraction. But we don't have an interventional bronchoscopist on call every weekend. So if one of us happens to be on, none of us really mind doing it. But if we're not on, we don't always promise to come in. So we have been doing the wing it call plan right now, which is working generally, but is probably not a long-term solution. So I mentioned CHOP because I know you have a little more complicated division of call schedule, which I think if you have faculty to do that, is probably where things need to go long-term to really like facilitate care.
Sorry, trying to get off mute. Okay. We do have an interventional bronchoscopist that's on call every single day, weekends and into nights. But we rarely do, we do cases after hours, but that's because the operating room just drags on all day. We rarely will get called in for cases after hours. In our hospital, a patient that has a foreign body that's an extremis, that's an ENT emergency. That's not a pulmonary emergency. It's usually in the central airways, and it's not going to be something that our cryoprobe is going to be the best or most efficient way of removing that foreign body. Our ICUs generally know that us, cleaning up the lungs is in the light of day when we've got backup and extra hands around, and we have all the right resources, people, our respiratory therapists that are going to be helping us with the scopes. Even though these are generally incredibly well tolerated procedures, complications in bronchoscopy, period, are just incredibly rare. But when they happen, they're a real complication. So, you want to have the right people around. It's not something you want to be doing in the middle of the night with a skeleton crew.
And I think
if you don't have to. Sorry.
I think when we started doing cryo, we primarily started in the OR. It was a much more controlled environment. You had all the right people there. And now, we do cryo all the time, including in the middle of the night, because we have an interventional bronchoscopist on 24/7 in Cincinnati, and I've pulled out casts from plastic bronchitis kids and extremis in the middle of the night. Now we can go anywhere in the hospital. It's really nice equipment that is portable, and it makes it a lot easier to do some of these things, which is really nice. I don't recommend doing that in the middle of the night, but it does happen here.
And then we've heard everyone talk about like certain patient populations being really suited for cryotherapy in terms of things. When you think about children or patients who you've thought about, is there a certain disease type where you think it's better for cryotherapy? And then for other centers where there isn't cryotherapy available, are there certain diagnoses you'd be like, maybe refer to a cryotherapy session because it'll be better for them to have just cryotherapy as opposed to an intervention?
I mean, I think if you're an ECMO center, having cryo could be really helpful if you do ECMO at your institution, especially to help re-recruit those lungs as you want to come off of ECMO. I think the other things that we're using cryo for, we do, like I think Chantal said with the GPA patient, we do some airway dilation and then cryo devitalization to help keep those airways open. We have done some biopsies. We also are a transplant center, and so we do cryo biopsies from a transplant standpoint. And then we're using more cryo with other interventional techniques like EBUS for some of our oncology thoracic masses, lymphadenopathy patients to help decrease the number of thoracoscopic procedures that these patients need. And so that it's not just cryo, that's cryo plus, but cryo is really helpful in those situations.
Yeah, I can echo what Dr. Zak was saying. I think I use it the most often in the ICUs for either ECMO patients or kids that have just like really nasty secretions because they've been intubated for a long time. It just saves me time. And again, you could use a suction. So like if this was the middle of the night and someone who wasn't, experienced in cryo was on, they'll just have to suction. But cryo does save you time. And I think it's also better for the patient because it's a faster procedure. I have started using cryo more frequently for transbronchial biopsies, which I prefer because the pieces are just larger and I can more likely get alveolar tissue instead of using the tiny forceps that I've often not gotten sufficient tissue to make a diagnosis. Those cases aren't that frequent where I'm using it for transbronchial biopsies. And those cases are probably more difficult because we can have more bleeding and the risk of pneumothorax. I can say that I have probably felt and had all the complications you worry about with cryo already. So I do feel like I've had some of the growing pains, I've had bleeding, I've had a pneumothorax, I've dropped a foreign body in the airway. And so I do think it's super, super important to make sure you have all your ducts aligned before the procedure, making sure you're checking platelets, infusing platelets during the procedure. It is preparing for every possible complication because even though this procedure is the numbers and the data show how safe it is a very safe procedure. I mean, the complications can happen, and those rare ones when they do happen can be really problematic. And so just making sure you have staff that can help you. Like if you're doing foreign body, I generally let ENT know, hey, I'm using cryo. I have a possible foreign body. You don't need to be there, but I just want to make sure you're aware, or your surgeon, whoever it is, and make sure you're just prepared for bleeding. So I think I forgot the question, but hopefully I answered it.
Chantal, would you be able to elaborate too on, or any of the panelists, are there certain like strong contraindications where they would not be a good candidate that are maybe different or things that to look out for?
I don't use cryo if I want a specimen for culture. I don't know how other people feel about that. I don't know how clear it is. Like when you're doing biopsies and you may want it for culture and for a path. I don't use it for culture because I'm just not sure how well some organisms grow in it. And I generally will not use it if my platelets are low. I like to have platelets above 50 because again, I've just seen a lot of bleeding. So I don't know if other people have more like lower cutoffs for platelets before they use cryo. And even if you're using cryo for like endobronchial biopsies, like you're just going to have a little bit more bleeding than you would if you're using a tiny forceps. So it's just something to prepare for. I can't think of, and then for like critical lesions, like critical stenosis or stenosis of the trachea, like if it's a circumferential scarring, I'll only do part of it, like if I'm doing devitalization, because you should expect like post-cryo edema or post-cryo swelling. So if you treat the whole area, you may lose your airway right after or in the days following. So if you are going to do devitalization in the trachea, I would just probably do it in, steps or over the course of a few treatments.
Yeah, I don't know if there's any true 100% absolute contraindications to using cryotherapy. Generally, if they can tolerate a bronchoscopy, they should be able to tolerate cryotherapy, depending on why you're doing the procedure. There's lots of applications for cryo. And so if you're taking out a cast, you can generally take that out pretty easily with somewhat lower risks. And it's faster than, constantly using suctioning. But keeping in mind things like bleeding, pneumothorax, you got to be prepared to deal with all of those complications if you need to. And so the other nice thing is that we've got the 1.1 millimeter probe that fits down the 1.2 millimeter channel. So size is generally not a limiting factor if they can accommodate the 3.1 millimeter bronchoscope that we use. And so you just have to think through all of the potential complications and things that could go wrong. And if the risk benefit ratio doesn't line up in favor of benefits, then don't use cryo.
I agree with Sarah. I want to give examples of two recent cases I had. One of them was a kid who had chewed on almonds and it was stuck in the left lower lobe, and the rigid scope wasn't going to reach there. So I went down and took out the almond myself with the cryo probe. But then a few weeks later, I had a patient who was referred from another institution who was like 16-month-old who had a huge hazelnut and right mainstem bronchus. And for that specific case, rigid is the way to go. I think it's very, patient dependent, age dependent. I don't think there's any, reason to try to take out like a 5 centimeter, foreign body from trachea or the right mainstem by using cryo, because it's going to fall down and you're going to, have complications, and it's not going to come through the ET tube, right? So, which is another issue. So if rigid is the best way, I always let ENT know.
Yeah, cryo is one tool. It's not your only tool. One of the other advantages of cryo is you can use it in a high oxygen environment. You don't need to be in a low FiO2 environment like you do for some of the ENT equipment that they use.
And then I think I'm going to have one last question from us and then open it up to the panels. But audience, if you have any questions, put it in the Q&A, and I promise we're going to try and get to it. But as we're talking about like the cryotherapy team, who is your cryotherapy team? Who are the specialists you have sort of on backup or sort of on like who are the people you're getting involved when you're thinking about a case?
And from our standpoint, we have, go ahead. We have our pulmonologist, our interventional pulmonologist, and our respiratory therapist. And then the rest of the team depends on who else. It depends on the patient. So sometimes we'll have ENT available, sometimes we'll have surgery available. It just really depends. But every time it is the interventional pulmonologist and the respiratory therapist that's involved.
I was going to respond because I don't have as many resources as a lot of the other hospitals on this call do. And so it's usually just the interventionalist, the fellow, and our tech. I would say the most important person in all our procedures is anesthesia, though. I have so many conversations with an anesthesiologist if we're doing any like long case, and so discussing what you're doing with the anesthesiologist beforehand and making sure you're aligned so that they're not surprised as well with again like the bleeding or just being down there long. I think having a good conversation with them, and they're probably, I think, the second most important person on your team.
Thank you for that. Dr. Taylor, do we have any questions from the audience which we should be answering?
So right now, no questions from the audience, but if anyone wants to shoot us a question through the chat, we would be happy to read it for you and get our panelists to answer. Or you can raise your hand as well, and we can unmute you. So 2 options.
I don't know if I have 2 questions, which I don't know if I'm only having. So one, there was a question about how much funding is required to get your own equipment and how much is required to maintain it.
The machine itself is a one-time capital purchase. I can't speak to how much funding you need versus institutional support. I think that's going to be different wherever you are. I think the next biggest cost is the probes that are part of that you need to use to be able to do the procedures. They're disposable and they're often patient chargeable. So you do get some reimbursement for that. And so they tend not to be capital purchases. The smaller probes are more expensive than the bigger probes. But if you're doing these procedures enough, I think about 30 procedures will pay for the equipment. So not a ton to get your money's worth.
We have
And I'm also going to jump in and add that you also need to take into account and point out to administration that a lot of these cases would have to be transferred to other centers. So by having the equipment in-house, you can keep the patient there and provide better quality care and also have multiple procedures done in your center.
Absolutely. Or you can have transfers from other institutions to your institution, such as patients on ECMO who have, airway blood clots. If you could remove them at your institution, that's also, a positive.
Yeah, all of that should go into your business plan.
Or if what matters to your institution is cutting down on some of those hospital days, right? The length of hospital stay. If the patient is there for weeks on end because they're having trouble re-recruiting after ECMO, or they've got casts and someone needs to remove them, but you're trying real hard with airway clearance, this is a much faster way to help impact that.
Kubra, I think this question might be related to the comment you made earlier from Dr. Bonsall, but could you elaborate a little bit more about leasing the equipment?
Yes. So I would highly recommend reaching out to your IRB rep. And if you don't know who your rep is, on their website, they have like their sales team, technical team. You can kind of send an email, and they're generally very responsive. Once you find your own rep, you kind of need to get a contract with them. And you don't have to do this personally, but if you want to jumpstart the process, you can. I'm sure that, at your hospitals, there are business, admin people who can probably help you with that as well. It kind of depends on how you're leasing it, 6 months, 12 months versus like 24 months. So the monthly, prices will kind of change.
And the group also is wondering if you have safety protocols for bleeding and pneumothoraces and what strategies you've used when that happens.
Whenever we're getting ready, whenever we're doing a peripheral cryobiopsy case, we're always using an endobronchial blocker. And so that can be inflated in the case that you're having, say, a gush of blood or bleeding from that side of the lung. You can at least prevent it from. You can isolate that lung from the ventilated lung. And then you can tamponade, have bleeding stop, go and clean up, and continue on with your biopsies or whatever you're doing for that case. So that's kind of one of the things that we've always put into place. We also, just like we were talking about before, we're always talking with our anesthesiologists. So we always have a bleeding plan for most of our cases. Anything interventional, we have a bleeding plan for. So whether that's having Afrin ready, whether that's having tranexamic acid ready, whether that's talking about what kind of tube we might exchange for so that we can main stem, an endobronchial blocker, airplaning the patient to one side or the other to keep the blood dependent, turning the PEEP up, whatever the interventions are that we're going to do, we always have a plan in place, and we kind of talked about it beforehand so that everybody's prepared for that. For pneumothoraces, we generally, in the more high-risk cases, if it's a nodule or something like that that's really close to the pleura and we know that there's a chance, then we're talking with our general surgeons in advance, because at least none of my team is trained in doing chest tubes. And so we're talking with the general surgeons, talking with their nursing staff to get a chest tube set in the room, discussing where we would place the needle if we needed to decompress and those sorts of things. That's a great question and a great way to be prepared for some of these cases.
We have another question about about leasing the equipment, but how long did you lease it for initially before you were able to buy the equipment?
We are currently still leasing it until we get the capital equipment purchase approval. And as far as I know, you can lease it, as long as you want. Could it technically, the company kind of makes more money when, as you continue to lease it.
And then I see in the chat, we have a hand raised, John.
Yes. Hi, this is John Schuin from Helen DeVos Children's Hospital, Grand Rapids, Michigan. Could you describe for those who started first in their institution the credentialing process, who they got to help them, any barriers or suggestions for those of us who are starting first as first timers?
Is your question about what kind of credentialing you need, or is it about being feeling comfortable enough to do it, or convincing the folks at your institution that you can do it?
It's the latter. So because all of the procedures at our institution need to be proctored by someone with more experience, but when you're the only individual starting out, your only options are to use your adult colleagues. So maybe you don't have that restriction at your institution.
Credentialing is definitely something that you'll want to discuss with your chief of division and whoever would be in charge of that. It can sometimes be tricky. It's something I got grandfathered in by being one of the folks that did enough of it to start, that nobody had to tell me, have you done enough? Or, should you do enough? But, for our institution, we're having folks, we want, the criteria are that you've attended one of the courses, and that you've done X number of procedures, to show kind of a capability with the cryoprobe, with, say, our interventional team.
Thanks so much.
And I think if you don't have anybody there that's doing cryo, this is where using your reps can be really helpful, having them on site as you're doing these procedures to make sure that you are walking through how to use all the equipment, that they're helping you troubleshoot anything. And so when we first started doing cryo, we had Irby here for several procedures to start, to make sure that everybody was comfortable using the equipment. And once we started doing EBIS, we did the same thing. We had our reps on site to help us troubleshoot anything that came up. Because I understand if you don't have anybody there that's doing it, how do you start? And so that's when using the other resources that you have available is really helpful.
And along those lines, someone had put in a comment, one of the attendees has put in a comment saying that Irby will produce a return on investment worksheet if you ask them, and that can help get an idea of how many cases are needed to produce profitable revenue. I don't know any of these things. I am just reading it out, but that sounds like a great one.
I think with timing, we may just need to end it there. Do any of our panelists have any final comments or anything they'd like to share?
Like to say, any case you have, just publish. We need more evidence. We need to grow the community. So if you see good cases, submit it to ATS and the library and publish, and that way we'll grow the community together.
I think that's a really, really great thought. And I think in general, peds pulm needs more and more of their cases, and interventional pulmonology in general, from a pediatric standpoint. It's an exciting time to be in. So I just wanted to thank all of our panelists for making time in a busy clinical day. I know there have been all sorts of places y'all have been pulled from, so thank you for that. And then for all our attendees, it's Tuesday afternoon. This could not have been easy to make it work. So thank you for attending a great session. If there are any other questions, feel free to put it in and we'll try and get it across to the panelists. But like we've heard, there are many, many opportunities to get training for cryotherapy, and there's more to come. Thank you all and have a really nice afternoon.